the last couple of weeks talked about polyps, and then colon cancer, and then today is supposed to be rectal cancer. And the it's termed colorectal cancer, but rectal cancers are somewhat different than colon cancers, and so that's what we'll focus on today. So, Andrew and Miles, what's the big difference between rectal and colon, or rectal cancers and colon cancers? Guess what I'm thinking? It's a one-word answer.
They're fixed. The sphincter?
Just one. No, that's one.
What other?
There are lots of different things, but you can sum it up primarily in one answer.
The management?
Location.
It's not real estate.
Radiation.
Anatomy.
Oh.
Yeah. Single location.
Kind of, but not real good. Okay, so what are the differences in the anatomy, Andrew?
Rectal cancer is low down on the pelvis.
Yeah, it's low. Okay, that doesn't make a big difference, other than technically.
The blood supply is different than the colon.
The blood supply is a little bit different. How's the blood supply different?
It's not all. You only have the rectal vessels rather than the coming off the air.
Yeah, but what difference does that make?
I guess not much.
It makes a difference. What difference does that make, Mom? I'll put it this way, it's not the arteries.
The venous drainage goes into the systemic circulation instead of the portal.
You get a dual drainage. It goes both ways. All right, what's another difference? That's right. Got to do fourth year, all right. He's going to stay back for another year. No cirrhosis on all of the rectum? Distal 2/3 of the rectum. All right, any other differences?
There's a sphincter.
There's a sphincter. You didn't get that one in yet. But there is. There's a sphincter you have to be concerned about and care about. All right. So there are differences. The peritoneal reflection comes in at about the second valve of Houston. And one of the things that when you get consulted for rectal cancers and other people have scoped them and things like that, they just say rectal cancer, or they'll say rectal cancer and give some number which is close to meaningless, because they'll just kind of look down at the scope, and if it's a 500-pound person, they may have 10 or 15 centimeters eaten up by buttocks, which doesn't really count. So you want to know where things are. And to me, the things I like to do is, where is it in reference to the rectum, to the sphincter? And when you do a digital exam, is it at the sphincter? Because that's going to make a huge difference in what we plan to do on them ultimately. And then start counting the valves of Houston, 1, 2, 3. The second valve of Houston is at approximately the peritoneal reflection. And so that gives you somewhat of a clue. If the lesion is below the first valve of Houston, getting a little bit less likely to be able to reconstruct those patients down the road. So those are considerations that we use when we see these patients.
I have a quick question.
Ask it.
Routinely,
I'd rather y'all ask questions.
we hear people say, "Oh, I can get my finger around it," or "I can't," and I didn't know if that's something. I've looked for that anywhere in the literature.
I can't get my finger around any of them.
Okay.
So I've been a lousy urologist because I can barely feel the prostate. It's more interesting is it fixed? Can you move it around? That gives you some clinical ideas. And can you reach it? The top side makes almost no difference at all. So in getting around it, it's the bottom edge of it that counts. And so, again, you got the peritoneal reflection, and then you have a dual lymphatic and venous drainage, which means that a significant amount of the blood from the distal 2/3 of the rectum bypasses the liver, then goes into the systemic circulation instead of the portal circulation. And so that's going to affect outcomes long-term, more lung metastasis relative to colon cancers and things like that. Where the tumor is in relation to the sphincter involves how you can reconstruct the patient. If you have to take the sphincter out in an effort to do a good cancer operation, then hooking the patient back together is not good. Actually, I have a slide a little bit later where there's some people that very aggressively hook people back together. I'm not in that camp. Though you hook someone together does not necessarily mean that's the best thing for the patient. It might be great for your ego and maybe great for patients. Well, I got hooked back together. But if you hook them together and they live in the pins for the rest of their lives, have you really done them a favor? So it does take some clinical judgment, and we might not cover that just too well here. And then the other thing is that's different from the colon is radial margins. Now you do have radial margins for the colon, like stuck to the abdominal wall or stuck to viscera, and you can do an in-block resection. But as far as in general, trying to get radially around a colon tumor is not the primary concern, but it's very, very important on rectal cancers because you have a very confined space. Which one of y'all said is low down there? Andrew? It's low down there. And you've got bone, and you have pelvic sidewall muscles, and you have some vessels down there that will really ruin your day if you get into them. Like big time, have to pack the patient, come back another day to finish the operation, blood vessels. So you can't just say, well, I can go way wide out here because there's no way wide out there. And also, again, this is where the lymphatic and venous drainage goes out in these pelvic sidewalls. So getting radial margins is a technical challenge, but we also use adjuvant treatment to try to help us with that. But in general, if you have a radial margin of less than 2 millimeters, that's considered a bad prognostic indicator for long-term outcome on the patient. All right, those are the main differences I could think of in anatomy. Anybody have any that they think of that I forgot? Hey, I don't mind being taught. All right, so then when it comes to evaluating and dealing with the patient before surgery, you do the same things. You get some CAT scans, you get some lab work, in particular CEA, and that type of stuff. So Miles, what do you do differently before surgery?
So depending on where you are on your colonoscopy, you may need a procto to get an actual level.
Okay, we talked about that on the anatomy side as far as the relation to the sphincter, the peritoneal reflection, and that kind of stuff. But what other tests do you want to do to evaluate them?
Endoscopic ultrasound.
Endoscopic ultrasound?
Or an MRI.
Or an MRI. One other thing before I go to my next slide, so I don't have just too great of transitions, and we'll talk about the ultrasound and the MRI because it leads to something else. What will the ultrasound and MRI help you with? What's the reason to get them?
Better for so the ultrasound is good for T stage and for end stage. Better for T staging, I think 80% or something.
All right, we'll discuss that in a second. So why are you doing it?
For staging purposes.
Okay, why?
To determine if you need to do preoperative chemotherapy
and radiation. Yeah, the whole point is you need to evaluate the tumor further to decide on preoperative adjuvant treatment. That's different than colon cancer. We don't give preoperative adjuvant treatment for colon cancer generally. Now, on the ultrasound and the MRI, today, they used to talk about using endorectal coils, and actually, if my memory serves me correctly, LSU actually had an endorectal coil, and someone steam autoclaved it. So so they no longer had an endorectal coil. So that was a problem. That was a long time ago. But today, the MRIs are better, and in particular, they're high definition machines that can look. There, with a good MRI, there's no difference between the local staging of rectal cancers with the ultrasound. In particular, now the ultrasound may be a little bit better telling you if it's a T1 or T2 lesion, but what you're really trying to decide is it a T3 lesion. And there is no, the ultrasound is not better. Neither one of them are great at lymph nodes. About 80% accuracy, maybe 70, probably closer. You can tell if the node's big, but you can't tell if it's cancer. And so that's a difference, but it is what it is. There is some question on the adjuvant treatment, whether it should be given pre or post-operative. Today, the general answer is going to be pre-operative. It's your function's better. There's some suggestion that the results are better. Does anybody know why radiation works better pre-operative as opposed to post-operative? The theoretical reason?
Blood supply.
Blood supply. Why is that?
Free radicals.
Yeah, it's something with oxygenation. You need blood supply to the tumor while it's getting the radiation. And so it's considered that preoperative is better for that. Certainly if you do preoperative radiation, you don't cut out the bulk of the radiated tissue and then start using non-radiated tissue to reconstruct patients. And so that makes a difference. The adjuvant treatment is radiation and some 5-FU based chemotherapy, and today most time is just 5-FU. Xeloda is really common, given by mouth, and they don't have to have a port just right off, and they do pretty well with that. There is definitely better local control with preoperative radiation. And kind of the safest way to think about it is whatever you as an individual or your institution's local recurrence rate, if you add radiation, you cut it in half. If you're really bad, you have a 30% local recurrence rate, you get it to 15. If you're more where you should be at around 10%, you cut it to 5, basically. So it definitely improves local control, getting those radial margins. And then there have been a couple of recent studies that have suggested that it might be some improvement in survival. Wouldn't take that one to the bank yet, but it might help. So, yes, sir.
What about in terms of sphincter preservation, getting smaller margins closer to the sphincter?
Yeah, and certainly that's what the books are going to say. Little controversy with that. Even Dr. Stratton and I have a little bit of a difference in opinion on that. So, it's you know, in literature and within a practice. Some of my concern is that if it leads to you going through the old tumor bed in order to get your margin, that make me feel good. Because as of today, radiation therapy alone is not satisfactory treatment for rectal cancer. And so if you go through the old tumor bed, you're in essence saying, well, the radiation cured that portion. That's good. Well, I'm not quite ready to buy that, but there are people that do that and go through. The idea that shrinks it. Now, it can free up some of the adjacent involvement, and now you have a more mobile rectum, and you can get better distal margins that way. So yes, and that can very well be a quiz question, is would it, and I'd say yes to that answer, that radiation might improve your ability to reconstruct the patient. Anything else? All right.
I guess we have a question too. Is you know, we measure distance from the sphincters for the discussion about whether or not we can preserve your sphincter, and then, but that's based on their like when do we measure that? You know, when are we?
I like to measure it before they start their treatment.
So hopefully we've met the patient.
That's why we try to encourage them to get them to us before they started getting their treatment. You know, if they don't, you kind of have to make some guesstimates on where the residual tumor is. I really didn't have a slide to discuss a whole bunch, but preoperative radiation and chemotherapy can actually lead to no residual tumor a significant number of times. And I don't apologize for that, because I tell the patients that, you know, that means the pathologist looked at a lot of different slides and places, but there are billions of cells there. They have not looked at every one of them. And so right now, radiation alone is not satisfactory treatment, because it means there's some viable cells still in there somewhere, which you hope you've taken out in your resection. But the outcomes are better in patients that have complete responses. So you tell the patient that statistically they have a better outcome. All right, so surgical treatment. What's the surgical treatment, Miles? Let's go easy to hard.
LAR.
Okay, let's go easier, Andrew.
Just a transanal incision.
Transanal incision. So, what's that called?
Where you can have a TEM, or you can.
Yeah, that's what we can do here, is the TEM, transanal endoscopic microsurgery. They're not definitive studies out there yet. Kind of hard to design a definitive study that says, okay, we can take some of y'all and do a transanal excision, and some of y'all we can do a TEM, where we think the TEM is better. That was going to be a little hard to get through an IRB. But in general, the approach is that TEMs give better local incisions. The candidates are patients that have T1 lesions. Controversy on T2 lesions. I have steered away from the T2 lesions. At one time I did them. Now I would recommend definitive treatment unless the patient has significant comorbidities that would make a big operation not as good.
What if you went after a T1 lesion and then final path showed it to be a T2 lesion? Same good features and whatnot.
I almost had that recently, pretty close. I would have a big sit-down discussion with the patient, but in general recommend that they have a definitive operation. With T2 lesions, the local failure rate's in the range of 20%. And there, as of right now, there's not good information that says that radiation therapy dramatically improves that. There have been some studies that showed that radiation did not help it, but it's still being looked at. Yeah.
Would you do a definitive surgery without chemoradiation at that point then?
If it was T2 lesion, I'd probably do it without chemoradiation. So the candidates for local excision of T1 lesions, generally not the big lesions, less than about 3 centimeters, less than about a third of the bowel circumference involved. They must be well differentiated, and the path not include lymphatic or vascular invasion. Even with T1 lesions, Dr. Colo and I got in a big debate about this a couple of years ago when I had a 26-year-old patient with a T1 cancer. And the local failure rate is about upper single digits for those lesions, where if you do a definitive operation, it's lower single digits. But there have been a couple of good studies that did long-term follow-up, and even with the variation in local control, the survival is no different. And that the patients that have T1 lesions, if they're going to get in trouble, they generally can get in trouble from metastatic disease, and a lot of that's pulmonary disease. So, yes?
They have referenced to one of the studies that they did for patients with T1, T2. T1 lesions, when after the surgery came as T1, they didn't do anything else. For T2 lesions, they gave them chemoradiation, and disease-free survival is kind of equal for those two groups.
Yeah,
Is it the standard?
No, there's been some other studies that didn't match up, and so it's still questionable. I suspect that there's going to be a move toward doing the T2 lesions just because it's less invasive to do the TEMs. I mean, there are also people, and I can cover all the variants, there's some people that are doing radiation and then coming back and doing a TEM. And that's a little scary too, in radiated section of rectum. So there are some variations in there. I'm not going to cover every example, but those are the things to think about. All right, I don't know if all of y'all seen, but basically the TM's using a big 40mm scope and multiple ports to go in with laparoscopic instruments and take out the lesion. All right, so what's total mesial rectal excision? Have you heard the term?
Yes, sir.
Okay.
Well, it could be an LAR, I guess an APR, but you have to get the mesorectum around the lesion using sharp dissection. Ensure you're getting all the lymphatics.
You do that by using your dissection plane as the endopelvic fascia and staying outside of the fascia. So you take the retrorectal fat as a packet and totally include it. And the mesorectum ends 2 or 3 centimeters proximal to the sphincters. There are some studies that have suggested that if you do good total TMEs, that you might not need to be doing radiation. There's some European studies along those lines, and that's an area of interest. But it is imperative to stay behind this plane when 15 years or so ago, I saw a lot of our fellows that came in that their desire was to go down through that fat to get to below the lesion, or kind of go tangentially down and not really get the fat adjacent to the lesion, and that's not good for their long-term outcomes. If you do a good TEM, you should have a shiny surface, and it'll be kind of bivalve down here. And so it's worth looking at the specimen. In a skinny patient, it's really easy. In the 500-pounders, it's real hard. So if that's your goal, you try and get a good lymphadenectomy. All right, not much time. So just a couple of things on the surgery. The other thing to remember is impotence in males, to talk to them about it. A lot of them will have retrograde ejaculation. That's not uncommon, but some will have trouble with erections, and if you let them know ahead of time, then they're less surprised after surgery. And I also want those patients to talk to me about it so that I can then send them to a urologist if they need some assistance. And you have to have the discussion about permanent colostomies in these patients. About 60% will end up with an APR. You know, that depends on where you are and how aggressive you are in trying to reconstruct patients. But coloanals, just because you can do it does not mean it's the best thing for the patient. There's a term for coloanal syndrome, and the patients typically after a coloanal will say that they will have a day or night that they're up all night evacuating their rectum. They'll have 10, 15 bowel movements to evacuate. Then they'll go a couple of days and have no trouble. Maybe you can have some normal bowel movements in there. And then they'll have another day or night with multiple bowel movements. I call them their good days and their bad days. And with time, and I'm talking about a year or two, those good days start to be more and the bad days start to be further apart, but they're not normal. And generally, as patients get significantly older, then I would advise them against it because it's just too hard for them to accommodate. Just real quickly, is if the lesion's down and you can come across at the top of the sphincter, they can be hooked back together. If you're down involved in the sphincter, you probably shouldn't hook them together. There are some people that get pretty aggressive on doing these, and I have my concerns about the patient's functional outcome. Again, I mean, if the patient gets a buy-in, they usually want that. but have you done them a big, big favor or not? And we'll stop there so that we can have more interesting stuff.
Whenever you're doing your transanal, you just, for a second until you see the fat bulging out, you take some of that perirectal fat.
I like to take that fat to get down there. And the young girl that I mentioned, I think I had 2 or 3 negative nodes.
So you want to get some nodal tissue if you can on the journey.
You are disappointed if you get nodal tissue.